Hi, everybody, and thanks so much for the honor of speaking with you today. It's been a fascinating experience to participate in yesterday's discussion and already this morning's. I'm a family psychologist who's worked since finishing my postdoc as a clinician, educator, scholar, and administrator at the University of Rochester Medical Center for the past 32 years. I study, write about, and teach physicians, psychologists, and other clinicians about the biopsychosocial approach to medicine, professionalism, and team-based care. You might say that family psychology is the original team science. How do we find new ways to teach about an approach to creating and carrying out a shared social contract that ensures multiple health disciplines working in concert and worthy of the trust of patients and the public? Drawn from a 2009 article on healthcare team competencies in the Southeast Asian Journal of Medical Education, we want methods to teach all our students to demonstrate shared understanding, new forms of leadership, team support, and communication. So what are the professional barriers? What are the professional barriers to doing so, and how do we dissolve those barriers? These are the topics that, from my perspective, working to integrate behavioral health into primary care and into the rest of healthcare, I'm going to address today. And I'm hoping that you'll find some of what I say transferable to your own settings. One of the first issues about changing the attitudes and skills for our health professionals of tomorrow involves how we select them in the first place, in admissions or hiring. Traditionally, at least in medicine and psychology, we don't select for the competencies I just described. Rather, we select people who value autonomy, highly competent individuals who prefer to control their own work and distrust administration. If we continue to select for these attributes only, we get the workforce that we have today. The alternative is to have search committees and admissions committees include members from other health professions and patients and select for mission-centric, team-ready, emotionally intelligent health professional faculty and students, people who will align with the values of transdisciplinary professionalism. Once we've identified such students, we need to help them develop strong professional identities as well as strong collaborative skills, whether they're physicians, psychologists, nurses, nutritionists, pharmacists, physical therapists, secretaries, or MAs. One of the exercises I use to raise the consciousness of groups working on integrated psychologists into primary care is to ask the medical professionals to give me adjectives that represent the public stereotypes of psychologists. Then I ask the psychologists to do the same for physicians. People usually go for the negative stereotypes. I don't know why. I've done this hundreds of times in more than 20 countries, including China, Mexico, Germany, and Romania, to name a few. So these are countries with vastly different systems to finance their health care, different cultures, and different languages. And to my surprise, the adjectives are universal. Here's a sampling of what they say. Physicians are cold, controlling, arrogant, pressed for time, technicians. Psychologists are cerebral, impractical, touchy-feely, and from a physician in London, right-brained and left-winged. Had to change my slide after he came up with that one. If we've absorbed even a few of these stereotypes, it's a wonder we're ever able to work or respect each other. I'd like to share a teaching video that amplifies this point. This is a real family physician trying to work with a real psychologist about a fictitious patient. In the interest of time, I'm just going to show you the opening minutes of this 4-minute video.
Maybe Sue McDaniel can help me with this case.
Hello, this is Dr.
Dr. McDaniel.
Hi, Sue. This is Dr. Campbell from over at the Family Medicine Center. I've got this patient I'd like you to see, but I just got a minute to tell you about her. My waiting room is full of patients, and I'm already 45 minutes behind. Now listen, she's a 16-year-old prima gravid at 34 weeks gestation, complicated by some intrauterine growth retardation, mild preeclampsia. The problem is that this lady just won't come in for her tests. She is really impossible, and I've tried everything. I keep telling her that her baby's going to die if she doesn't do what I tell her. Can you see her? I'd really like you to convince her to come in for a prenatal test.
Boy, Tom, I can hear you're really upset. I notice you call this woman little lady. Do I sense you're ambivalent about treating her as a girl or a woman? What do you think's going on? Is she depressed?
I don't know. That's your department. But if you think she should be on antidepressants, I know the ones that are safe in pregnancy.
Seems like you're jumping to medications rather quickly, Tom. I want to know something about the person of this patient before we rush into pills to fix it. What do you know about her family?
I don't know anything. I don't have time for that stuff. It's hard enough dealing with her medical problem, but I think her boyfriend's on drugs. So I checked her for AIDS and told her not to have sex with him.
Boy, this case is really getting to you. Is information about her significant other factual, or is it some discomfort of yours in dealing with patients from a different background than yours? You're pretty angry at her, you know.
What the hell are you talking about? I'm not angry at her. I just don't want to be responsible for her delivering some gorked-out kid. So the rest of the satire continues to articulate the many ways we can go wrong in working together. This is one way we deal with professional tribalism, to elevate, examine it, and challenge it. This approach can be extended, obviously, to stereotypes with all health professionals. I have another tape with 16 different health professionals making fun of themselves that I did when I was part of the Primary Care Policy Fellowship with Bureau of Health Professions. Anyway, Eduardo Salas, a psychologist who studies team functioning across industries, including healthcare, emphasizes the importance of what he calls task interdependence. Salas found that team training needs information, demonstration, practice, and feedback, but the most important are practice and feedback. An example of training with these elements comes from my Department of Family Medicine in what we call team collaboratives, a monthly mega team meeting of all staff in which all our 7 teams share their quality improvement projects so they can be generalized across the practice. A young family psychologist, Zipporah Rosenberg, has been running these interactive meetings of 120 people since she finished her postdoc with us 5 years ago. She provides information, addresses process, teaches task interdependence, models transdisciplinary professionalism, and highlights successes in an entertaining format. Frequently, our team collaboratives focus on an essential aspect of professionalism, which is communication. At this meeting, Zipporah suggested we repeat that game of our youth, telephone. She gave each team the message to convey down the line of people. Tuesday last week, there was the most incredible rainstorm, and it went on from there. By the end, most communications were about 8 to 10 words with few of the significant points. For example, one group said, it was raining, I had to catch the bus. We did another round, and this time the message included affect. Last week on Tuesday, the day of the big rain, you told me you were going to take care of that issue I talked to you about. I told you it was really important to me. You said it would be no problem and you could finish it before you left for the day, but you didn't. I'm confused about what happened and frustrated it's not done yet. One group reported, you said you'd take care of it, but you didn't. After a large group discussion about the problems with multiple communications and how emotion affects them, the whole group developed communication pearls they could all agree to. Number 1, keep it short. Number 2, actively check for understanding. Number 3, the electronic health record really is better for some communications. And number 4, it's important to be kind when giving feedback. Patrick Lencioni is a business consultant who focuses on corporate team building. Here are his 5 prerequisites of great teams: trust, conflict management, commitment, accountability, and focus on results. I'll share a couple of the exercises we use to enhance trust and conflict management. Trust, the foundation of good communication, requires vulnerability to be open to one another around mistakes, weaknesses, and fears. It's important to clear out political and hidden motivations
And for trust to develop across disciplines, it's especially important for leaders not to promote the myth of invulnerability. Here's an exercise to promote trust in teams. Tell us where you grew up, your birth order, your cultural background, and an important or challenging thing that happened in your childhood. I talk, for example, about how I grew up in South Florida, the oldest of 3 girls in a Southern WASP family, and that one of the most influential events for me was racial desegregation of the schools when I was in junior high. It challenged the stereotypes I had heard all my life, set me on a path to study stereotypes in college, and led me to work on cross-disciplinary teamwork in healthcare. Another example involved a physician who was quite disruptive in team meetings. In this exercise, he said, "I grew up in a poor neighborhood in Jamaica with a lot of illegal activity, racism, and violence. I learned to hurt people in order to survive, but came to realize this was wrong. The hardest thing for me has been to socialize myself, to learn not to behave that way anymore, to treat people with respect." This revelation changed the way his teammates understood this man and changed the way he functioned in the team. Managing conflict is a key competency for transdisciplinary professionalism. Productive, even passionate debate is important for healthy team functioning. Getting all the ideas out on the table and being able to sit with controlled discomfort rather than dismissing differences is more likely to yield positive outcomes. This requires patient, active listening, basing arguments on substance, not politics, pride, or competition. It means going after the best solution rather than trying to win. An exercise to work on conflict management is, how did your family air differences? What are your preferences about acceptable and unacceptable behavior during debate and disagreement, including language, tone of voice, emotional content, and whether you tend to participate or not? The team then works to develop its own norms about how to manage conflict and what's acceptable and unacceptable behavior. Issues of power and hierarchy inevitably come up when trying to do interdisciplinary work. We want a collaborative practice where the power of each party is fully recognized. The power of the physician, psychologist, or other health professionals to diagnose and suggest treatment. The power of the patient to make sense of the illness experience, decide, and embark in treatment, and the power of the family or social group to provide a healing environment. In a 1980 paper called Why Men Resist, William Good described how the sociology of subordinates says there are predictable feelings and behaviors experienced by those higher in the hierarchy, as well as those perceived as lower. In particular, those higher tend to experience their position in terms of feeling burdened and responsible rather than powerful, blessed, or lucky. Those lower can feel that their talents or accomplished go unrecognized. They are vulnerable to feeling invisible, unappreciated, disrespected, and eventually resentful. It's important to study what counteracts these problems. In his book Outliers, Malcolm Gladwell gives a compelling description of how Korean Airlines went from the worst safety record to one of the best by understanding how culture and hierarchy had resulted in flawed and incomplete cockpit communication. Desperate to fix the problem, Korean Airlines examined the cockpit recorders and found that, consistent with their culture, power and authority were never challenged. They found that worldwide, planes are safer when the least experienced pilot is flying because it means the second pilot isn't afraid to speak up. Once understanding the problem, Korean Airlines set about to create a different kind of culture in the cockpit, one in which hierarchy is flattened, first names are used, and the co-pilot is rewarded rather than dismissed for disagreeing or speaking up. The same principles of communication and flattened hierarchy have been found to increase safety in surgery and other healthcare teams. Many issues of power and communication are taught through the so-called hidden curriculum in professional training, what students see modeled by professors regardless of what's taught in didactics. Changing the hidden curriculum means creating a culture that welcomes rather than avoids feedback. My last example is a program that builds on this concept of feedback to increase communication skills and change the hidden curriculum for professionalism. It's called the Patient and Family-Centered Care Physician Coaching Program. I developed and direct this program over the past 2 years in response to the need to focus on patient complaints and patient experience as a driver for reimbursement. To begin this program, our medical center leadership endorsed a set of values that spell out I care. integrity, compassion, accountability, respect, and excellence. Each job family then developed their own most important eye care job behaviors. Clinician leaders voted for 8. Then I took 3 primary behaviors associated in the literature with improved quality and patient satisfaction. For ease of memory, I labeled them ICU. I for introduce yourself and your role to your new patients and families. C, to ask about patient and family concerns early in the interview. And U for check for understanding about the diagnosis and treatment plan. And I started with the chairs of the departments and senior clinicians. I spend half a day with each physician, observing them seeing patients, inpatients or outpatients, and complete a coding sheet for each patient interaction. Here's a compressed view of the coding sheet. At the end, I develop a composite report that summarizes the data on all the behaviors, including those involving other team members, and write a qualitative part on each interview section about what they did well, ending with 2 or 3 concrete behaviors they might want to work on. They receive the written report, and we meet again to discuss their strengths and areas for improvement. In addition to determining what skills most need targeting, another part of the pilot was to determine feasibility, with many physicians telling me they themselves were interested, but other physicians wouldn't be interested because they didn't like to be told what to do, especially by somebody who's not a physician. However, this definitely hasn't been the case. I had virtually no negative ratings in the anonymous survey of the pilot. You can see 60% physicians considered the coaching very helpful and 40% found it helpful. Comments included, I believe this type of experience is valuable since habits, good or bad, creep into communication. Very professional, insightful. I'd like to do this again. And my favorite, very truthful and very helpful indeed, even though it was truthful. This is from a South African physician. This year, I've trained coaches of different disciplines to increase our coaching capacity. One of the coaches, psychologist Bill Watson, recently said, an advantage of coaching is that it's innovative, interdisciplinary, and it vividly conveys the important idea that a necessary foundation of transdisciplinary professionalism is openness to feedback, diminishment of professional hubris, and respect for the value that other disciplines bring. The idea that we all have blind spots, don't know everything, are constantly missing things, can improve our practice in critical ways, and most importantly, can learn from others who are not of the same discipline. One could say that coaching is subversive in a good way to the dominant culture of the disciplinary silo. We also need research to further inform our work in teaching transdisciplinary professionalism. I have a study coming out in the next few months in the Journal of General Internal Medicine called Physicians Criticizing Physicians to Patients. This is a qualitative study that demonstrates how frequently we professionals diss each other. We must find other healthier outlets for our inevitable frustrations rather than taking them out on our colleagues and teammates. I want to end on an upbeat note. I asked my psychology postdoc, Lauren DiCaprio, to have a conversation with one of her medical teammates about how they see their work together. She chose a young family physician, Ian Dauchke. It's a fascinating conversation with the best of what we want in transdisciplinary professionalism. But for the sake of time, let me show you 3 brief clips that add up to 3 minutes, and that'll be it.
All right, so as we were thinking about what makes us effective collaborators and the values that we share, I think there were sort of 3 key things that stood out for us. The first being the way that we value patient-centered care and our approach using a biopsychosocial model to understand our patients and the systems that impact their lives. And I know that there's been a few patients that we've had where that's been really quite meaningful, but there's one in particular that stands out to both of us, I think.
Yeah, I mean, I think given that we both, share that value, it comes across in all of our interactions and with all of the patients that we've shared. As it happens, I saw one of them this morning, so that's, on my mind, and she probably is the best example of that, given the amount of interactions that we've had and the number of times that we've been able to collaborate in her care. I certainly think that she is a complicated patient from many respects, from her medical aspects. She's got a number of comorbidities that make her, make any visit with her challenging because there's just so much to manage. She's also followed by a number of specialists, and from a primary care perspective, coordinating all of that care is difficult. And then add to that, she has significant difficulties with anxiety and mood disturbance, as well as seemingly difficulty with trust, with providers in particular. And all of that in the context of a family system that isn't always the most functional or beneficial to her. And so, unfortunately, she hasn't really been coming to the office to see you as much as I think either of us would like most recently, but you do have a fair amount of experience with her, and from that, you've been able to draw on your interactions with her and really help me in my interactions as well in coming up with ways that I can communicate better with her and her family in trying to move her care forward.
I think the thing that I value in our conversations is the reflective nature that we take about how we can each individually be a better provider in the room with her, and how to have those conversations in a way that she feels heard and feels supported, but still feels productive and meaningful to us. And so there's just a general approach that we take in hearing each other through that process and figuring out ways to work with her and to work with her family that I think is really quite meaningful to all of us.
Yeah, I agree. There certainly have been things that I've learned from our conversations, about her that I can apply to other patients in how to better interact with them and how to engage them a little bit better in the process and in advocating for themselves, as you've said.
I think that transparency also helps us professionally in a different way, in that it gives us the opportunity to talk about really complex cases and not feel alone with these really complex patient individuals, families, and systems that aren't always easy to work with. And so at the end of the day, knowing that I have your support in this individual's care and in others becomes really quite meaningful. And there's a transparency in identifying our own limitations when working with these folks that I think is really quite beneficial to the work that we do and to the care that they receive.
Yeah.
So we all want to work towards this level of transdisciplinary professionalism. Thank you.
Thank you, Susan. That certainly gave us a lot to think about. Now I'd like to introduce Jacqueline Slomka from the School of Nursing at Case Western Reserve University.